Okay, sorry, Bebo. There was a problem in this one. We forgot to record it till now. Now onwards, we will record it. Okay. Now, we are now going into the fact of the matter, where the whole idea of reading immunology is to know the immunization schedule. You must know the ACVIP as well as the Indian Academy of and the Indian Academy of Pediatrics. What's the full form of ACVIP? Can you tell me this is the ACVIP recommendation. ACVIP here is written, I have written it here. Gopika, you are there or you disappeared? You are there? Hello?
Sir, Advisory Committee on Vaccine and Immunization Practice.
Advisory Committee on Vaccines and Immunization. Very good. What is ACIP? I think this is Rose is there, isn't it? Yeah. What's ACIP? Here you have said Advisory Committee on Vaccine and Immunization is ACVIP. Very correct. That's by the Indian Academy of Pediatrics. What is ACIP? Advisory Committee on Immunization Practices. Remember, this is CDC America. But those two are different. This is the immunization schedule, which we will not go. You must know, you must read it, and you must know it, not from it. Anyway, I will not go into a detail about it. We will talk about it in detail later when time comes. Now, the question here is, this is all the immunization schedule by the ACVIP on various ages. Now, our question is not that we are going into individual vaccines equally and asking you why is the schedule for that particular vaccine. Now, this is the vaccine schedule in National Immunization Program. Go and read it from the book itself in a condensed way. If I would run through it, you will find that BCG is hepatitis OPV 0 pentavalent vaccine, and here you are giving rotavirus 1, 2, and 3 here, 6, 10, and 14 weeks. Now, along with that oral polio, you're giving fractional polio in 6 and 14 weeks. I think they have started giving it 9 months also. Rose is there. Are they giving fractional polio in 9 months? Any idea? Anyway, this is the vaccine schedule I could get in the current immunization schedule I could get. And what is the rationale behind it? They are giving even now MR vaccine. I think the Kerala government, the IAP of Kerala is pushing for MMR vaccine, and they might soon introduce MMR vaccine in the schedule. Now let's come. That's not what we are interested in. I would like to ask you a simple question. Now, at birth, we are giving OPV. You understand? We are giving hepatitis B. We are giving BCG. Who all are there? Is Majida there? Hello?
Yes, sir.
Majida, why are we giving oral polio at birth? Among all the vaccines, we have selected 3 vaccines to be given at birth. Why are we giving oral polio at birth? What's the reason? Gopika, are you there? Gopika left or what? Ashwati?
That prime the immune system.
Prime the immune system. Now, my question is, why don't we give DPT also? Diphtheria, pertussis, tetanus also. Why don't we give? Won't the OPV be, when you give it, won't it be neutralized by the maternal antibodies? What are the reasons we give OPV at birth? It's the first question. Okay, you should know it by this time at least. Read it now.
Herd immunity.
Okay, can you see it? You read it now.
Birth dose of OPV while
A dose of OPV administered at birth or as soon as possible after birth can significantly improve the seroconversion rate doses and induce mucosal protection before enteric pathogens can interfere with the immune response.
This is the most important as soon as possible. So the other enteric organism which might multiply and compete with OPV are not there. The gut is essentially sterile and therefore giving it. Okay.
Okay, sir. Giving the first OPV dose at a time when the infant is still protected by maternally derived antibodies does not carry the risk of inducing VAP,
What is VAP?
vaccine-associated paralytic polio.
Yeah, this is because this is a new thing which has come about. Very rarely the vaccine dose, the OPV which you dose can change into what you call we have attenuated it, but it may become a pathogen. It might multiply, mutate, and become a pathogen, produce paralysis. Therefore, less chances of mucosal and more chances of it possibly a significantly improved seroconversion rates because there's no competition. It goes in a sterile gut. And this is given in IPA guidebook in 2018. I didn't find it in 2023 book. There's no maternal IgA in the gut to neutralize the virus. Therefore, the virus can multiply at the what you call gut because there is nothing to prevent it from multiplying. There's no maternal IgA in the gut at that time. Therefore, there are solid reasons. This is given for priming. Remember this. Once you give OPV at birth, it stimulates the memory B cells. It may not stimulate much of antibody. More chances of it being uptake. There's no competition. These things are therefore this you must be very clear. Why are we giving BCG at birth now? Can you tell me why BCG we give at birth?
Prevent disseminated T.
See, we would have preferred to give all vaccination at birth rather than at 6 weeks or 6 months because the patient is in front of you. The child is in front of you. Give it at birth. You may, if you ask them to come back at 6 weeks or 10 weeks or 14 weeks, a certain percentage, maybe even 5% may not come back for the dose. Therefore, there's more chance. The child is there in the hospital, you can give. Therefore, whatever vaccine you can give, you will give at birth. Now, read about BCG, okay?
BCG is the only currently used human vaccine for which there is conclusive evidence that T cells are the main effectors. The T cell responses are more robust, long-lasting, and are more cross-protective than humoral responses. Hence, modern vaccinology is being directed in this direction. The inherent T cell mediated immune regulatory mechanisms prevent any vaccine from causing autoimmune diseases.
Okay.
The Calmette-Guerin vaccination at birth in healthy preterm infants born after 32 to 36 weeks of gestation was found to be safe and effective. For BCG vaccination of very low birth weight and extremely low birth weight infants, there are insufficient data to assess safety, immunogenicity, and efficacy. Based on current evidence, early BCG vaccination is recommended in stable infants who are preterm and or low birth weight.
Okay, now the one of the we will be discussing preterm vaccination later on, but one of the thing is that the preterm vaccination is also based on the chronological age. Okay, therefore, if the child is stable, you give the vaccination immediately. Only hepatitis B, I think you should wait till 2 kg. What you are given before may not be counted. But generally, I don't know what's happening in our newborn unit. When do they give the vaccination? Suppose you have 1.5 kg or 1 kg child. Is the baby given a BCG at birth? Hello, Ashwati, you are there?
Yes, sir.
Is Amal there or not logged in?
Login Amal.
Okay, why is is BCG given at birth now here in a 1 kg child? Actually, most of the neonatologists would prefer to give their vaccination at the time of discharge when the child is 2 kg or nearby. But that's not what medicine says. Medicine says you can give all the vaccination on the baby is stable. But the problem is when you give an immunization, even the immunization, what happens is the children might sometimes develop apnea and other problems. But anyway, the actual practice is supposed to be at birth. Uh, Now, regarding BCG, okay, read it now.
A single dose of BCG vaccine should be given to all healthy neonates at birth. If missed in the neonatal period, the vaccine should be administered at the earliest opportunity. BCG may be given in newborn period as the maternal antibodies actually enhance T cell responses. BCG can be co-administered with the hepatitis B vaccine. Catch-up vaccination can be done till 5 years of age. Pre-BCG Mantox test is not recommended till this age.
Okay, this is a very important point. May be given at newborn period because maternal antibodies enhance is something which I did not know till recently, and this might be the reason. There may be newborn maternal antibodies may enhance T cell response. It doesn't interfere because T cell immunity is fully developed. T cell is completely developed in the newborn period. But for these reasons, BCG can be given at birth, and we prefer to give vaccination at birth so that the take rate, we don't lose the babies later on. Therefore, the take rate will always be higher. Whether you revaccinate, we are just going through it, okay?
Studies have shown minimal or no evidence of any additional benefit of repeat BCG vaccination against TB or leprosy. Therefore, revaccination is not recommended even if the TST reaction or the result of AGRA is negative. The absence of a BCG scar.
Okay.
The absence of a BCG scar after vaccination is not indicative of lack of protection and is not an indication of revaccination. Based on limited available evidence from small observational studies conducted in different high TB endemic settings, BCG vaccination at birth in healthy preterm infants born after 32 to 36 weeks of gestation was found to be safe and effective. Evidence regarding BCG vaccination of very preterm and extremely preterm infants is limited.
Okay, this is we have given that for BCG can be what we want to know from the immunological point of view. T cell dependent vaccine. T cells mature. T cells are cell-mediated immunity is well developed in the newborn period. It can be given. Further, the antibodies stimulate the T cell response. Therefore, BCG can be given at birth. Regarding preterm, 32 to 36 weeks, definitely effective. Very low preterm babies, there's no evidence. Therefore, you might wait up to 32 weeks to give the first dose. These are now, is universally BCG being given? May I ask you a question? Is it given in all over the world? Hello?
No, sir.
Who's this?
Even in TB prone areas only.
The first male voice I'm hearing. Is it Monish?
Yes,
Mohsen?
sir.
Okay. So, Mohsen, what is the where is it given in Western countries?
Not
In-
every country.
Not given in Western countries.
Not given in Western countries. Okay, in America it is not given. That is why in Kawasaki they don't talk about the BCG scar becoming bigger when you have a Kawasaki because they don't give BCG. But that's not the point. They give in UK and all. They have a system of giving it if the parents are of Asian origin, if the parents are certain indications. So limited population they do give. But do they give at birth? Limited number, they don't give it birth. They give it 28 days. Do you know the reason for that? And just out of interest, I'm telling this, you can read it. Read it now. If you are appearing for MRCP, this becomes important. Can you read it?
On advice from the Joint Committee on Vaccination and Immunization, NHS England and Improvement recently revised the timing of this vaccination to 28 days after or soon thereafter. Neonatal BCG in UK is risk-based. To prevent inadvertent immunization of any newborn with severe combined immunodeficiency, the BCG program has been uniformly shifted as of September 2021 to post 28 days of life. This change is being adopted nationally for safety and consistency for all babies.
Actually, if you have a severe combined immune deficiency, if you give BCG, it will produce tuberculosis in the patient. Therefore, to prevent this, they have started screening for severe combined immunodeficiency. And therefore, the BCG program has been uniformly shifted to 28 days. This is just for interest. And talking now, we give hepatitis B at birth. What's the reason for that? Mohsen, can you explain the reason for giving hepatitis B at birth? No, I think we are wasting time. We are not able to answer fast. Okay, now you read it.
For killed vaccines such as DPT, HIV, and pneumococcal and hepatitis B, which are administered as early as birth or 6 weeks, the first dose acts only as priming dose, while subsequent doses provide an immune response even in the presence of maternal antibodies.
Now, this is the immunization schedule in the, I don't know why it came 2021. It's just 2023 also. You find that the dose is the third dose. This is the CDC schedule. They give only 3 doses. Okay. The first dose is at birth. The second dose is actually at 2 months. 2 months completed. Here they have written first month or second month. I'm not too sure about it. And the third dose is given at 6 months completed. And this is then not at 18 months. Afterwards, there's no booster. Remember this. Therefore, now the routine series, please read what is given here. Routine series, can you read it?
Three dose series at 0, 1 to 2 and 6 to 18 months. Use monovalent Hep B vaccine for dose administered before age 6 weeks. Then infants who did not receive a birth dose should begin the series as soon as feasible. Administration of 4 doses is permitted when a combination vaccine containing Hep B is used after the birth dose. Minimum age for the final 3rd or 4th dose is 24 weeks. Minimum intervals dose 1 to dose 2 is 4 weeks or dose 2 to dose 3 is 8 weeks and dose 1 to dose 3 is 16 weeks. When 4 doses are administered, substitute dose 4 for dose 3 in these calculations.
Now remember why I'm putting it up very slowly, why I'm showing the CDC table first is to understand that hepatitis B is a disease which we are giving. We give the newborn dose because the maternal to infant transmission should be, if it is there, should be blocked as much as possible. If you immunize at priming dose 6 weeks, we want to make the child immune as far as possible. Even if the mother is a HBs positive, if you are giving without giving antibody, if you are giving only the antigen, it's about 80 to 90% effective. If you are giving antibody also, it's about 99% effective. Therefore, the newborn dose becomes very important to prevent maternal to newborn transmission. That's the most important thing by newborn vaccination. Among all these vaccines, hepatitis B is the most important. And when the child develops hepatitis B by transplacental transfer, the chances of liver carcinoma are very, very high. That's why we are very concerned about newborn vaccination. But there is a problem here. They are advising only 3 doses, 0 dose, 1 to 2 months, and 3 months. They say that if you want to give combined courses, you can give 4 doses. But what is happening in our place is that we are giving in the, if you look it up in the National Immunization Program, we are giving at 0, 6 weeks, 10 weeks, and 14 weeks. We are giving 4 doses. but the last dose is given at 14 weeks. That is not, therefore, we are giving the last dose before six months. And we are not giving any booster in the universal immunization program. While in the while the Indian Academy of Pediatrics, so many of the, if you look at the immunization schedule being followed in our hospital, what our people do is they give at 0, they give at 6, 10, and 14 weeks, and then they give a booster at 1.5 years. 1.5 years, they give a booster. So they are giving 5 doses, 0, 6, 10, 14, and then therefore you are giving extra doses. Okay, that's what the Indian Academy of Pediatrics says. But there's a problem regarding that also. In immunization, you are giving something to a child who's absolutely normal. Therefore, no side effect is allowed. Not like giving antibiotics 7 days instead of 5 to a sick child. It's absolutely normal. Therefore, there should be full justification for you to give an extra dose. You can't just take it very lightly and say no problem in giving an extra dose. But still, that's what is being followed. I just want to show. Therefore, the last minimum interval between the first and 2 dose 4 weeks, dose 2 to 3 is 8 weeks. When you give only 2 doses, the booster between the booster and the last primary should be minimum 8 weeks, and the first and the last dose should be 16 weeks. The most important dose, the last dose should not be given before the child is 6 months of age. Now let's see. Now this is what the CDC says. Let's see what the WHO says. Can you read it?
WHO recommends multiple options for adding hepatitis B vaccine to existing infant immunization schedule without requiring additional visits for immunization. Schedules should optimize the percentage of children completing the hepatitis B vaccine series, which can be achieved with earlier administration of vaccine. The WHO recommended minimal interval between doses 1 and 2 is 4 weeks, and the minimum interval between doses 2 and 3 is 4 weeks.
Yeah. Between 2 and 3 is actually 8 weeks. I think there's a mistake in that. It should be 8 weeks. Okay. I don't know why it happened. Okay. Now let's go to the next one.
Schedules with these minimal intervals, like 6, 10, and 14 weeks, have zero conversion rate similar to schedules with longer intervals, albeit with lower final anti-HPS concentrations.
What they are telling is if you give it 6, 10, and 14 weeks, which complete the longer interval have a lower anti-HBs concentration. See, what we are worried about is this vaccination schedule is, see, hepatitis B, we are very worried about transplacental transmission. But we are also worried about transmission in the adult, when they become adults, adolescents and adults, when they'll be using drugs, when they might be sexual contact, etc. Therefore, this should recommend. We are not giving any booster. 1.5 years is not given in the Western world because the WHO recommended can you read this now? I think the new slide has come. Yeah. Read this also.
The WHO minimal recommended intervals for infant hepatitis B vaccination are shorter than those recommended in the US. Although data are limited regarding long-term protection for schedules with shorter intervals, alternative schedules are often not feasible. In addition, concerns about long-term protection are of less practical significance in countries of high endemicity where most HPV infections are acquired in childhood.
Therefore, they say that even if you don't give boosters at the right time, you will come in contact with the HPV. Now look at the IAP immunization schedule at 23. This is the immunization schedule of hepatitis B. Okay, you look at hepatitis B. Here it is there. Now I want you to note it. Hepatitis B is given here. Now, what is important is there is no booster at 6 months. You understand? Therefore, the last dose, you are giving 4 doses, agreed, but the last dose is given at 14 weeks. Therefore, we are not following the basic recommendation because this is the final dose. This is the booster. There's no other booster after that. Therefore, the final dose you are giving before 6 months. which should not be actually according to basic immunology. But then, but in our hospital, they are giving it 18 months, I think, combined vaccination, which contains hepatitis B. I'm not sure, you check it. Now look at what Nelson says. Read it. Can you see what's come up?
If the DTaP, Hep B, and IPV combination vaccine is used, a 4-dose schedule is permissible, which include the standalone hepatitis B vaccine at birth and the combination vaccine for the next 3 doses. CDC schedule is for primary vaccination is 0, 2, 4, 6 months. So last dose is given at 6 months.
See, remember that in Western countries, they give it 0, 2, 4, and 6 months. And sometimes they slipped, they don't give it 4 months, they will give it 0, 2, and 6 months, 3 doses. Now, but the last dose is given at 6 months. But according to our schedule, the last dose is not given at 6 months. Therefore, there is a small issue regarding that. But other than that, why is hepatitis B given at birth? Why? What is the significance? Is all you should know very clearly. Is given at birth. Is very important to give at birth because transplacental transmission we want to prevent. If you get a needle prick and get an hepatitis B, the chance of cirrhosis are much less than when you get it from the mother. And that's why hepatitis B is given at birth. But then 6 weeks, 10 weeks, 14 weeks alone may not be enough. 6 months should be the last dose, which may not happen. Therefore, what we are doing in our place, giving at 1.5 years a booster dose may be given, may be worthwhile. But the problem is you are giving the 5th dose. You just cannot add on doses. And when you are giving it for healthy children, whatever side effect it may develop, may have medical legal significance. Nowhere it is given that you can give 5 doses of the hepatitis B. But WHO says this schedule is okay because you will get infections from the surrounding. You are always exposed to hepatitis B according to them in developing countries. Remember this in back. Therefore, if you can push the dose to 6 months and can give a hepatitis B when you form the schedule, it will be very good in your private immunization. Now we come to the next vaccine, MMR vaccine. Okay, read it now.
MMR vaccine, routine vaccination, minimum age is 9 months. Administer the first dose of MMR vaccine at 9 months of age, second dose at 15 months, and the third dose at age 4 through 6 years. Catch-up vaccination ensure that all school-age children and adults have had 2 doses of MMR vaccine. The minimum interval between the 2 doses is 4 weeks. 1 dose if previously vaccinated, then with 1 dose. In campaign mode, MMR vaccine can be administered irrespective of the administration of the previous doses.
So over here, this is a live vaccine. You understand? What's the rationale of giving it 9 months of age? Can you tell me? While the Western countries give MMR at 1 year, we are giving it 9 months. Why? Come on, you must be able to answer this question. Why we are giving it 9 months of age? Who is there? Mohsen? Ashwadi, Majida, do you know or don't know? Can you hear me?
Yes, sir.
Answer that. Otherwise, why do we give it 9 months?
Breakdown.
Huh?
Measles breakdown.
They say that in conditions where countries where it's endemic, like India, it is supposed to be endemic. Below 1 year, measles is supposed to occur in about 5 or 10% of the population of the measles cases. And these measles cases are more severe. Maybe the mother was not immune, there was no antibody transfer, they are more severe. And the death and mortality is more in infancy when compared to above. Therefore, they want to give at 9 months. When it give at 9 months, we learn from immunology that maternal antibodies inhibit the live viral vaccine very much, even up to the age of 1 year. Therefore, it may not take. Therefore, that's why we are giving a second dose at 15 months. And then the IAP says give a dose at 4 to 6 years also. Why? Because measles is one of the most infectious diseases. And they say that by looking at it, school children, if you give at 15 months, some of the school-going children do develop measles, though mildly, and they may spread it to other. Therefore, to boost an immunity, though it is not goes with the basic immunology. Live vaccines normally don't require boosters, but because they keep on multiplying in the body, they produce important memory B cells, etc. But still, we are giving a booster at school children. But if you have a school-age child, 2 doses are enough. The minimum interval between 2 viral vaccines should be 4 weeks. 1 dose is given, you can just give 1 more dose. That is good. Now, in a campaign mode, suppose somebody is giving an MR campaign. This happened recently. We had an MR campaign in school age. Every child will receive the MR. Now, remember, in Kerala right now also we are giving, we will come to that later. Okay. Now we are talking of routine vaccination. Remember this. Okay. Can you read it?
MR vaccine in routine vaccination, universal immunization program. Dose 1 is administered at minimum age of 9 months or 270 completed days. Dose 2 is administered at 16 to 24 months. Catch-up vaccination up to 5 years. For catch-up vaccination, minimum interval between dose 1 and dose 2 should be at least 4 weeks. Measles containing vaccine can be administered to infants aged 6 through 11 months during outbreaks. These children should be revaccinated with 2 doses of measles containing vaccines, the first at ages 12 through 15 months and at least 4 weeks after the previous dose, and the second dose at the ages of 4 through 6 years.
Okay. Therefore, they are given a very complicated thing here. The universal immunization program, normally there's no dose 3. Though the IAP is advising a school entry, the universal immunization program, remember, measles vaccine is not their MR, and they are not giving MMR, they are giving MR vaccine. We will come to that later. MR vaccine. Now, the catch-up immunization is up to 5 years. Catch-up means those who had not taken up the vaccination. We would like to give the vaccine at fast as possible. Therefore, 4 weeks interval, we will give 2 doses. Now, during an epidemic in the hospital, you can give doses as young as 6 months to 11 months during an outbreak, but we don't calculate it. 6 through 11 months is not correct because 9 months you are supposed to give the 6 through 9 months it should be. Now, we don't take it into consideration. We revaccinate the children with 2 other doses. At the age of 12 to 15 months, at least 4 weeks after the previous dose, and the second dose through 4 to 6 years. I don't know why when you're during a measles epidemic, you give the first dose at 7 months, you give the second dose and give the third dose only at school entry. Because in universal immunization program, there is no dose at school entry. While the Indian Academy of Pediatrics gives a dose of school entry, you may be asked, why does the IAP advise as school entry? Because it's school entry, children come together. And when they come together, there's a more chance of acquiring chickenpox. Subclinical and sometimes mild chickenpox can happen in the immunized children also, but they will transfer it to other children. Therefore, we would like to give 1 immunization when they enter the school entry. Okay, read it.
The MMR vaccine, if administered within 72 hours after exposure to susceptible individuals, may prevent or modify measles disease and is the intervention of choice for post-exposure prophylaxis in immunocompetent host. Post-exposure prophylaxis is not of much benefit against mumps and rubella.
This is important because you may get a measles child, 8-year-old child, and the mother might say, Doctor, my younger child who is 8 months or 10 months, I have forgotten to take the MMR vaccine or MR vaccine. What you do? You might think that he's already exposed, therefore I will not give it. But actually, you should tell him that there's a chance that it might prevent. That is, if you give the MR vaccine, the incubation period is very interesting here. I think the next slides would give you some idea. Read it now.
The incubation period, measles 8 to 12 days, rubella, the incubation period following respiratory exposure averages 14 days with a range from 12 to 23 days, and mumps ranges from 12 to 25 days but is usually 16 to 18 days.
Stop it here. I want to tell you something about incubation period and protection. Now, I forgot to tell it about hepatitis B, because in hepatitis B, why do we not give the booster doses? Because in hepatitis B, once the memory cells are elicited, we have seen it in video 1, but you may not be remembering it. The memory B cells start acting within 7 days, 7 to 10, definitely by 10 days. Therefore, when the virus attacks a child with the incubation period more than 7 days, the memory B cells will look into it, and therefore ready-made antibodies are not required. That is why in hepatitis B, which has an incubation period, I think somewhere between 2 to 3 months, it is not in hepatitis A and hepatitis B with long incubation period, it is not required. But for patients who have a short incubation period, this is like influenza, which is 2 days, 3 days, your memory B cells are not going to be effective because they take some time. Ready-made antibody should be there. That's why we are giving immunization almost every month, every year. Booster doses are also required. Now, normally, how does the measles has an incubation period of 8 to 12 days? When you give the vaccine, it starts acting within. Before that time. Therefore, it might protect a child who's already exposed to measles from developing a severe measles. Surprisingly, in children with a longer incubation period with rubella and mumps, it seems not to be effective if you give the MMR vaccine once the patient is exposed. That's something different. Now, last paragraph is also important. Remember this, read this.
The National Technical Advisory Group on Immunization observed that since the disability component of mumps is not a serious public health problem, and since the addition of mumps component to universal immunization program would result in a substantial increase, that is more than twice than that of rubella vaccine, in cost without commensurate public health benefits, MR vaccine should be introduced instead of MMR.
This is the decision of the National Technical Advisory Committee. Now, I don't know whether you are in current knowledge. We had some mumps encephalitis. I think there was some mumps death also. This is what happens. And there was a panic. And the Indian Academy of Pediatrics, the Kerala branch, is pushing for MMR vaccine. What's the most important point of mumps? Mumps usually produces what is called as unilateral deafness, known to produce orchitis, but sterility is not that common, produce pancreatitis, and then in older children produce pancreatitis. It does produce encephalitis, but it's not supposed to be very severe. But we did have severe encephalitis following mumps and mortality also. Therefore, we are pushing for MMR vaccine also. Remember this. Okay. Therefore, incubate this, leave it now. Now, remember that how we are giving MR vaccine here in India in the universal immunization period is 9 to 12 months, 16 to 24 months. And what's happening in the this one is we are giving it first dose is 9 months, second dose is 15 months. I forgot to highlight that it is given at we are giving it 4 to 6 years also. This is the basic difference. I've told you the immunology behind that. Okay. That is, we are giving only 2 doses in the universal immunization program. We are giving 3 doses as per Indian Academy of Pediatrics, because this MMR is given because during school entry, the chances of getting chickenpox are very high. Therefore, we want to prevent it. Therefore, we are giving it. And it is advised by the ACVIP, but it is not universally. WHO is not advised. Universal immunization is not advised. These things you should know very well. Now we will come to certain vaccines which we don't give regularly, but something should be done. Now, regarding varicella vaccine, chickenpox vaccine. Majida, suppose somebody asks you, should chickenpox vaccine be given to your children? Ashwati is there?
No, sir. Ashwati.
What?
Wardlote.
എല്ലാരും മോഡലോട്ട് പോകും. അപ്പൊ ആരുണ്ട് അവിടെ? Who's there?
Mohsin and Majida.
Mohsin, Majida. Now who's talking? Gopika is not there. Where are these people going? What happened to Lasima? Amal, I don't know, is there. Okay, Majida. And who else is there? Majida and Mohsin.
Mohsin.
Okay, Mohsin. Your child is, how old is your child, Mohsin?
4 years, sir.
Have you given varicella vaccine?
No, sir.
Is it in the, what does the ACVIP says? What does the WHO say?
2 doses can be given, sir.
It's not a question of
Right.
can be given. Why is it given? Is it necessary? When you are a pediatrician, you should know what is the basic immunology, what is the basic need to give, what is the basic need not to give. Why is it not in the immunization program? Is there any need to give? Is there any worry about varicella vaccine? This is what they will ask you. Majida, what do you say? Should you give or not give? If the patient, you see, you are going to be in private practice 90% if you don't join the health service. And even if you join the health service, mothers are bound to ask you, doctor, should I take chickenpox vaccine? What will be your answer? Mohsin has not given to his own child.
That for national immunization schedules.
Huh? What does CDC say? Center for Development Studies in America. Are they giving in Western countries? How can you be a pediatrician without knowing this? Okay, read this.
A varicella vaccine individual use advisory committee on vaccines and immunization practice recommends the following. To all healthy children with no prior history of varicella, with a special emphasis on all children belonging to certain high-risk group as enumerated below, the vaccines are licensed for age 12 months and above. However, the risk of breakthrough varicella is lower if given 15 months onwards. Hence, ACVIP recommends administration of the varicella vaccine in children aged 15 months or older.
Okay, read it.
After a single dose of varicella vaccine, approximately 15% of vaccine remain at risk of developing a breakthrough varicella disease. These varicella infections immunized population may raise concern regarding varicella encephalitis and misunderstanding by physicians or parents who may lose faith in vaccination. 2 doses of varicella vaccine offer superior individual protection as compared to a single dose. The ACVIP now recommends 2 doses of varicella vaccine for children of all age groups. For primary immunization, the first dose is best administered at 15 months and the second dose should be given 3 to 6 months after the first dose. However, during an outbreak, the first dose may be administered at 12 months of age if it is ensured that the 2 dose schedule will be completed by the individual child. The second dose may be administered anytime 3 months after the first dose. For catch-up vaccination, children below the age of 13 years should receive 2 doses 3 months apart, and those aged 13 years or more should receive 2 doses at an interval of 4 to 8 weeks apart.
Therefore, Mohsin, you are not following the ACBIP recommendation, the recommendation of the Indian Academy of Pediatrics. Okay.
Sir, national immunization doesn't give varicella vaccine, sir. So
What's it?
national immunization schedule,
Yeah.
they don't have varicella
See, the
vaccination.
point, that's what the
But
fundamental point you should understand is in national immunization, cost is a major problem. Okay, they will not tell it openly, but that's a fact. That's why you don't give, see, there are many things which WHO has recommended, we don't give it. For example, human papillomavirus, HPV, strongly recommended by the WHO. We don't give it. Pneumococcal vaccine was strongly recommended in 2011. In the Indian government started giving it much, much later. Therefore, cost is a factor. Now, when varicella, there is a concern about varicella. What is that? What's the concern? about varicella. Even some pediatricians have this concern. Therefore, remember this, that you have given 2 ACBAP vaccines. Here, there are certain questions to be asked. Number one, the second dose, only 2 doses are given, not 3 doses, not even for a booster. Should be given 3 to 6 months after the first dose. What is the meaning of 3 to 6 months? Why is it 3 to 6 months? This is a live vaccine, is it not? Therefore, the live vaccines which we are giving are, one is MMR and the other varicella. Therefore, they don't have to be exactly 6 months. Therefore, 3 months, but the minimum interval between 2 live vaccines have to be 4 weeks. For better duration, we try to make it the dose difference as much as possible more. The more the interval between the first and second dose, the longer will be the antibodies lasting. Therefore, we would like to make it 6 months. But the problem with chickenpox is highly infectious. You postpone the second dose, we may develop a chickenpox by that time. However, during an outbreak, the first dose may be administered at 12 months of age if it's ensured that 2-dose schedule will be completed. The second dose may be administered any time 3 months after the first dose. Remember all this. And if it is below those age 13 years, should receive 2 doses at an interval of 4 to 8 weeks. Why 4 to 8 weeks for children about for people about 13 years, and for children below 13 years, it is 3 to 6 months. It is because we want the antibodies to last for a longer time. And probably the immune system is better developed in 13-year-old children. Now, why do we give 2 doses? Because normally live virus vaccine, single dose should be enough because they cost. But the efficacy to moderate to severe disease is 95% even with a single dose. And 2 doses, it is 100%. But what is the complication we are very concerned about? Even now, pediatricians would say about it. Something called the epidemiological shift. What is epidemiological shift, Moses? Anyway, we'll read it in the next. Can you read it?
All high-risk children, however, receive 2 doses 4 to 8 weeks apart, irrespective of age. Susceptible household contacts of immunocompromised individuals can safely receive the varicella vaccine, since there is no evidence of transmission of the vaccine virus from the vaccine to the contact, and even if it was to occur, the disease is likely to be very mild. If the vaccine develops a vaccine-related rash, he or she should avoid contact with a susceptible immunocompromised contact. There is growing evidence against concerns that waning immunity will lead to higher complication rates due to an increased age of acquisition. Likewise, epidemiological concern about the uncertain effect on herpes zoster longer term have not been proven to be linked to varicella immunization.
Now, this is a very important point. There's something called epidemiological shift. Certain diseases is better that you have at young age, and chickenpox is supposed to be one. If you have chickenpox at young age, the chances of complications are less. Now, if you occur at a later age, it seems to be older people, you have more complication. Therefore, the worry is you give immunization in a newborn period at younger age, and instead of it being a childhood disease, this shouldn't become an adult disease. Therefore, growing evidence against, this is against concerns of, it has come in multiple journals. I have quoted it from Archives of Pediatrics in 2018. Therefore, you can say that with emphasis that there's no problem. Then some people will say, okay, you won't get chickenpox in young age. You may get more herpes zoster, which is more dangerous. You can lose your eye, the pain can be very severe, etc. But there also, there's no evidence. Remember this. This is very important point to remember. The epidemiological shift, if you give 2 vaccine, there's no evidence that is occurring. Further, if there is more chickenpox in adults, you will find neonatal chickenpox because mothers may get infected and you may get neonatal chickenpox, which can be very dangerous. Therefore, this concern is there about epidemiological shift. That's one of the reasons many people are not giving it. But remember, Dr. Mohsen, it is up to you to decide whether your child should receive or not. But with all his wisdom, the Indian Academy of Pediatrics is advising it. That's it. Tomorrow, 2 children die of chickenpox encephalitis. Immediately, the papers will be filled, and Kerala government may be stimulated to give the vaccine. So this is the ACVIP recommendation: 15 months, 18 to 19 months, 2 doses. There is no dose of school entry. Okay. They are not written about school entry, is it not? No HP. No, they are not written school entry. No, yeah, MMR is there, school entry. Varicella is not there. Remember this. Okay. I don't know whether you noted. Look at the regime. What you had to look in regime in USA, varicella vaccine is usually at 12 to 15 months, second dose at 4 to 6 years. The difference is only that the rest is same as in our group. They will remember we are giving the first dose at 15 months, and the second dose we are giving at 18 to 19 months. Now, there is a view in some people that give the second dose at school entry because that's the time at which you really require a booster of vaccination, or give 3 doses, just like MMR. But majority of the people by the ACVPA has gone with 2 doses, 15 months and 18 months, and no dose in the school entry. While the Western countries, they give it 12 months. I think they give it usually given a 12 to 52nd dose is school entry. They don't give after 3 months. Therefore, there's a such regime in America. Okay. I just want to see, and I know even second pass to see. There were regime a second dose minimum interval windows to that. Now read the last line, last paragraph. The World Health Organization. Remember, read that.
WHO suggests that the first dose of varicella vaccine be administered at age 12 to 18 months, and that the second dose for countries with a 2-dose schedule be administered at the recommended minimum interval provided by the vaccine manufacturer, ranging from 4 weeks to 3 months.
Okay. Now, why do we say that it is 3 to 6 months? The longer the interval, the longer will be the higher will be the antibody titer. Between the when you are giving 2 doses, the second dose is actually the final dose. You can't call it booster because it's a live viral vaccine. But you can give it with a minimum interval of 4 weeks. When do you give it with a minimum interval of 4 weeks? Because when you postpone the second dose, there is a chance that he may develop a mild attack of varicella. Therefore, during epidemics, you may give it within 4 weeks. About 13 years, you try to give it at the interval of 4 weeks because he's going to school, he's going to college, going to the hostel. Therefore, we want to prevent chickenpox. Therefore, we give 2 doses 4 weeks apart. Because sometimes the parents will come and say, Doctor, he's going to such and such a place, is good. Now, remember, Mohsin, I'd like to tell you one thing. Apart from all this, in the present day world, it is better to immunize the child. Because if he has an exam, you say CBSE exam or some other exam, and she develops a chicken pox, she straight away loses 6 months to 1 year. At that time, there's no point in regretting that. And further, when there's an epidemic of chickenpox going and when there is an exam, you will always be worried whether my child will develop. So it's better in the present stage to give the 2 doses vaccine separated by 6 months. Your daughter is now 3.5 years. Give the first dose, give the second.
Actually, sir, I had given 1 dose. My sister had varicella, so we all had taken 1 dose only, sir. Single dose.
Yeah, well, we have seen that before. That we have looked at it. 1 dose. Look at it. Seroconversion 86%, 99% for 2 doses, and efficacy in mild disease 70 to 90. Here's 98.3. Moderate to severe, 1 dose is only 95, while 2 doses 100%. Therefore, you give the second dose also. Why do you want to wait?
Yes, sir.
Okay. We have gone through all this. Now we will go through the other vaccine which is regarding is hepatitis A. Hepatitis A, is it advised by the ACVIP? Any idea? None of you would read it now.
Hepatitis A dosage schedule. Indian IAP and ACVIP recommends 2 doses of inactivated hepatitis A vaccine given intramuscularly, with the second dose administered 6 to 18 months after the first dose. Minimum
Okay.
age
Yeah. Okay.
minimum age for giving hepatitis A vaccine is 12 months.
Now, they are giving the administered between administered 6 and the inactivated intramuscularly, second dose 6 to 18 months. Chickenpox, they say 3 months, even 4 weeks. Why? Because you can get it. The chances of developing hepatitis A after 1 dose is very less. That's why they say you can even give it between 6 and 18 months. Don't give it before 5 months. There's no hurry in giving hepatitis A the second dose. While chickenpox, there can be a hurry. That's what it is. Live vaccine. This is more, they're both live and intramuscular. We have live and kill vaccine, I think. Okay. The comparison, we have inactivated and live attenuated vaccine. Mohsen, do we have, what do we have in our clinic? Live or inactivated vaccine? Any idea?
Inactivated.
Huh?
Inactivated vaccine.
Inactivated vaccine. Is it available in India, hepatitis A live?
It's-
Are they giving it routinely? They are not giving it, but you should offer it to the patient. Remember this, because inactivated vaccines available in India are Haverix, GSK, 3 vaccine, live attenuated, only 1 brand. Biovac A is marketed in India. Remember that you have to talk about all vaccines, which is advised by the Indian Academy of Pediatrics, especially, which is available in the market with the patient, and tell them the indication. Why I'm telling you this is one of my very close friends, his son went to what you call engineering college, got a hepatitis A, and almost died. But 6 months he lost because he had a severe attack of viral hepatitis A and died. And most of our messes in the major colleges are very bad hygiene is there, especially in North India. Therefore, it is better to vaccinate our children against hepatitis A. But there is a problem that we will come to that later in that. Therefore, we are more concerned about 2 doses, 6 to 12 month interval. I am more, the first dose is given more than 12 months apart. Now, this is what it is now. Can you read through it now?
Hepatitis A and hepatitis B do not need regular boosters, as the long incubation period of the disease allows for activation of the immune memory cells. Increasing the dose of vaccine antigen may also be sufficient to circumvent the inhibitory influence of maternal antibodies, as illustrated for hepatitis A or measles vaccine.
Okay.
Epidemiologic shift. This refers to an upward shift in age of infection or disease in communities with partial immunization coverage. Owing to vaccination, the natural circulation of the pathogen decreases and the age of acquisition of infection advances. This is especially important for diseases such as rubella, varicella, and hepatitis A, wherein severity of disease worsen with advancing age. Single dose
Yeah,
to be
okay.
given for the live attenuated hepatitis A vaccine. The inactivated vaccine needs 2 doses.
Our concept when we were students was live attenuated vaccine, single dose is enough. But now we are giving multiple doses for most of the viral vaccine, MMR, everything. But later on, we will realize that nowadays, for typhoid vaccine, now it's a kill vaccine, they are advising single dose. Human papillomavirus, now it's a subunit vaccine, DNA. We will come to that later. They might even advise single dose. But for a live vaccine, which previously parental live vaccine, because they are supposed to produce the primary and the secondary immune response with a single dose. Most of the vaccines we are advising second dose, because MMR vaccine we are advising 3 doses, varicella we are advising 2 doses, but the only live attenuated vaccine, which is not available in the market, the single dose is advised is hepatitis A, because we get lot of that's a reason why we give a single dose of hepatitis A. The government supplies it us with hepatitis virus in all our body, in our food, as well as we get our boosters recurrently through our food and water. That might be the reason. The same is true of typhoid also. They say though it's a killed vaccine, single dose may be enough. Now, epidemiological shift is, for example, rubella. If it occurs in young age, no problem. But if it occurs in an older age, in a adolescent period, what will happen is if they get pregnant, their congenital rubella becomes a problem. Varicella and hepatitis A are more severe in adults than children. So we don't want, we give immunization, it should prevent the disease totally. Not therefore, this is the screen which you give. You give 12 months hepatitis A, single dose live attenuate. They have advised at 12 months and the booster dose after 6 months. Okay, this is what is given by ACBIP. Now, Mohsen, have you given your child typhoid vaccine?
Sir?
Have you given your child typhoid vaccine?
No, sir. No.
Yeah. Is it advisable to give typhoid vaccine, or what does the ACBIP say?
6 to 9 months we can give, sir, typhoid conjugate vaccine.
It's not a question of can give. You should tell them,
It
you
is.
are a pediatrician, you should
We have to
say,
follow.
does the WHO advise it? Number one. We know that's not given in universal immunization program. Therefore, the
Yes.
patients will come and ask you, should I give or not give? How many doses? Is it available? It is available. Should we give, or does the WHO say that?
National immunization, no, sir.
National immunization, no. We know what's given national immunization. We don't have to apply our mind too much. You are in a health service, you can just give what you want. But now the question is, now read about it fast. IAP recommendation.
Typhoid vaccine. Both VIPS, polysaccharide and PS conjugate vaccines are available. Minimal age, polysaccharide 6 months, whereas VIPS vaccine 2 years. Vaccination schedule, VIPS single dose at 2 years, revaccination every 3 years. And there is no evidence of hyper-responsiveness on repeated revaccination so far.
Hyper-responsiveness, okay.
Hyper-responsiveness so far.
Okay.
VIPS conjugate vaccine, single dose at 9 to 12 months. Catch-up vaccination recommended throughout the adolescent period, that is till 18 years. IAP prefers the use of VIPS conjugate vaccines.
The conjugate vaccines are always preferable, okay? Because they now polysaccharide vaccine, I don't know why they are talking so much about it, but this good evidence is that you have to revaccinate every 2 years, but there's no hyper-responsiveness, unlike the pneumococcal polysaccharide vaccine, where if you give a second dose, there will be hyper-responsiveness. Therefore, it is recommended, okay? 6 months by the IAP. I have no doubt about it. What does the WHO
recommends vaccination in response to confirmed outbreak of typhoid fever and in humanitarian emergencies, depending on the risk assessment in the particular setting. The potential need for revaccination with TCV is currently unclear.
Okay, leave it now. Let's go to next.
Revaccination is recommended. Among the available typhoid vaccine, TCV is preferred at all ages in view of its improved immunological properties, used in younger children, and expected longer duration of protection. The IAP strongly urges the government to include typhoid vaccination in the UIP, considering the enormous burden of the disease, not included at present. The WHO SAGE Working Group on Typhoid Vaccines has recommended only a single dose of TCV at any time between 6 and 23 months of age in the endemic countries, further corroborated by the published 7-year follow-up data of Typhoid TCV-19.
So remember this very carefully. When you talk to a patient, tell him that both the IAP and the WHO, okay, advises typhoid vaccine. Remember, hepatitis A advised by the WHO and IAP. Remember, influenza vaccine advised by WHO and IAP. If you don't
Yes, sir.
say like that, you are at a varicella, again advised by the IAP, is it not? Am I right?
Yes,
But
yes,
you
sir.
must know what is at least what is advised, what is the age, what is the reason. Why is now, if you look at the IAP schedule, typhoid conjugate, the 6 to 9 months. Remember, this is by the IAP. Conjugate vaccine is a killed vaccine. Still, they don't advise booster. That's a funny thing in our by immunologically, live vaccines don't require boosters, but we give boosters for MMR, varicella. We give many live except for hepatitis A. Everywhere it is given booster. Killed vaccine boosters are required, but conjugate vaccine you don't give. They have not written it here, but I read it somewhere because salmonella is so ubiquitous that one dose is enough. That the salmonella which you get from your food and water will act as a booster dose for you. That might be the reason. Remember this typhoid vaccine. Now, may I ask you one question? Why is WHO so concerned about typhoid? It's not so common. In Kerala, it's not so common. North India and all, it is. I don't know about the government hospitals whether they're getting typhoid at all. Why are they so concerned about typhoid vaccine? Because antibiotic resistance has become a big problem. Typhoid is salmonella has become resistant even to ciprofloxacin. There's no antibiotic to treat, especially in Pakistan and all that. Therefore, to prevent antibiotic resistance, they have now advised they are going all out for a typhoid conjugate vaccine. That's one of the reasons why WHO is pushing. It's not a disease which you can treat that easily. Now about the influenza vaccine, I think we are catching 5 o'clock, but I'll step a little because you came late, I think. Is the influenza vaccine advised? Mohsin?
Yes, sir.
Uh,
6 or 7 months.
6 months and
And
7 months. Okay. Now with the quadrivalent vaccine is available. Read it fast now.
influenza vaccine. Globally, quadrivalent inactivated vaccine and live attenuated influenza vaccine are available. Most of the current seasonal influenza vaccine include 2 influenza A strains and 2 influenza B strains, that is quadrivalent. The trivalent vaccines are not in use in most countries.
Read the
IAP
IAP.
recommendation. Risk groups for severe influenza include pregnant women, children aged less than 5 years, elderly, and individuals with comorbid like HIV, PID, chronic lung, cardiac disease, etc. Minimum age 6 months for uh,
Inactivated
inactivated.
influenza virus. Yeah.
Okay. Minimal age 6 months for inactivated influenza vaccine, 2 years for live attenuated influenza vaccine. First time vaccination 6 months to 8 years, 2 doses 4 weeks apart. 9 years and above single dose. Annual revaccination with single dose. Universal dose is 0.5 ml IM. Quadrivalent influenza vaccine is preferred over trivalent influenza vaccine. There is no much difference in efficacy between split variant versus subunit vaccine. Apart from non-severe allergy to vaccine compliance or to a previous dose of inactivated influenza vaccine, there are no contraindications. Use the most recent strains containing vaccine in the pre-monsoon period.
Pre-monsoon period, before the start of the monsoon. Therefore, we should be giving it at what time? Our monsoon starts in June, is it not?
Yes.
Yeah, May end we should be giving it. But the first dose can be given anytime after 6 months. Remember, according to WHO, if you have vaccine only to give to one group, that should be pregnant women. But please ask how many of our obstetricians have given to their mothers. I'm not too sure. Your wife received it during pregnancy, flu vaccine?
No, sir.
Yeah. The WHO says they are the highest risk group. Remember this. Number one, next is children below 5 years. This is the IAP recommendation, 5 months, 7 months, 0.5 ml. It could be, I don't know why 1 month apart you can give, but why they are written 2 months, I don't know. 4 weeks apart you can give, but seems to be 2 weeks apart, 8 weeks apart. Then every year till the age of 5 years. Remember, now if you're following the ACVP immunization, you should offer flu vaccine to these patients, especially children who have recurrent wheezing. Remember that. Now, I think this is the final one, human papillomavirus. We will read through it. Human papillomavirus, is it advised by the WHO, IAP? HPV vaccine, 9,000 rupees.
Yes, sir. Yes, sir. IAP.
Yeah,
9 to
because
40.
you remember, cervical cancer is the second most common cancer in women, and is only one cancer you can prevent by immunization. Never now remember, read this fast. Okay.
Human papillomavirus. Human papillomavirus vaccine. The quadrivalent and non-valent vaccines have been licensed globally. The bivalent vaccine has been withdrawn from the
I
Indian
think it
market.
is nanovalent vaccine. 9 vaccine. Non is a mistake. Nanovalent.
Sorry, nanovalent vaccine. The bivalent vaccine has been withdrawn from the Indian market. Both vaccines are manufactured by recombinant DNA technology that produces non-infectious virus.
Why did I say non-infectious virus-like particles? It is actually a killed vaccine. It's not a live vaccine. Okay. Can you read
Both
that?
vaccines, yes, sir. Both vaccines are manufactured by recombinant DNA technology that produces non-infectious virus-like particles comprising the HPV L1 protein. The mechanism by which these vaccines induce protection have not been well defined, but seems to involve both cellular immunity and neutralizing immunoglobulin G antibodies. These vaccines do not protect against the serotype with which infection has already occurred before vaccination. Higher immune response is seen in pre-adolescent through 9 to 13 years as compared to adolescent in young adults.
All these are important. Why do you give only 2 vaccines between 9 and 13 years? It's because at that age group, there is a higher immune response. After 13 years, you will give 3 responses. 1. Now, second type is do not protect against the, if you are already infected, do not protect against if serotype is infection has already occurred. That's why they in adult, you see, you have a child at 9 years they plan to give because they think that in Western countries there's a chance of sexual contact by the time the child is 9 years completed. Therefore, in here you can start at any time after that. How that's changing, the sexual age of sexual contact is changing here also, but that is the reason why you stay at 9 years. Now that is one important thing, and how the number of doses, etc. What is, see, this is, I will explain, recombinant DNA technology. See, recombinant DNA technology altering the genetic material outside the organism to obtain, enhance, and decide characteristic in the living organism or their product. Involves the insertion of DNA fragments from a variety of sources having a desirable gene sequence via appropriate vector. This is a bacterial wall, this is a plasmid, the DNA of interest, you understand. And DNA of interest, plasmid, digesine, recombinant DNA. This is called the recombinant DNA. This DNA outside the cell, whatever in a human, the antigens of the human papilloma virus, which will cause the, is now introduced here, and then it is introduced back into the bacteria. Therefore, it will cause copied and cells divide. Therefore, the recombinant DNA is not DNA copied and cells divide. I don't know whether you should take it as a live vaccine or a kill vaccine, but whatever it is, recombinant DNA is a mechanism. And if you look at, you have your Cervac was 2, I think it had 4 strains only. Now we have 4 strain Gardasil as well as Gardasil 9. And it is given between 9 and 45 years, while nanovalent is given between 9 and 26 years. This can be given to males also. Therefore, now schedule of vaccine is 9 to 14 years, and the interval between the first dose should not be less than 5 months. This is very important. The individual between 15 to 26 years for females and male, 3 dose. See, 9 to 14 years, the 2 dose schedule, because they have more chances of but they develop higher immunity. Which, Mohsen, you are there with me?
Yes, sir.
Okay. Between 15 to 26 years, it is only 2 dose. Okay. You can read through this. And
Yes.
what I want to stress is prevention cervical cancer to global strategy acts eliminate cervical cancer should be included. They say they advise, they say, but they say should be included in the national program and should reach HPV in 90% of all girls by 15 years. Now, there's another thing which is come up. Normally, we are using the 2-dose schedule. The human papillomavirus, they say after the age of 13 or 14, they have written after the age of 15, you should give 3 doses. But now what has happened is the WHO has come down to 2-dose schedule. The current evidence supports the recommendation of 2-dose schedule be used in primary target group from 9 years of age for all age group with HPV vaccine. 2, they come down to 1. The minimum interval between the first and second is 6 months. A 12-month schedule higher titers and suggested for programmatic and efficiency reason. You can even make it 12 months. There's no maximum recommended interval between dose and longer interval 3 to 5 years if useful from a program perspective. Somebody has missed the dose, very costly, came back after 5 years, you can give the second dose. Between the first and second dose is 6 months. Now the WHO has come down from 3 doses to above 13 years or 14 years to 2 doses all. But they have come again, there is another issue. Now single dose has come. Therefore, what is the latest advance? They may come latest advance. What are the latest advances? Off-label option of single dose schedule can be used in girls 9 to 20 years. Data from immunity studies, trials, post-hoc analysis of efficacy trials, and post-licensure observation studies among females have demonstrated that a single dose of HPV vaccine is sufficient to elicit immune response that provides a similar protection as multi-dose regime against initial and persistent HPV infection. This may offer program advantages, more efficient and affordable, and contribute to improved coverage. From a public health perspective, the use of a single dose schedule can offer substantial benefit that outweigh the potential risk of lower level. Therefore, those single doses now come about in the literature. Antibody level has done. Field studies have not been done. Therefore, they are now advising 2 doses. But remember that the IAP is advising below 14 years, I think 2 doses, and above 13 or 14 years, it's advising 3 doses. Remember all this in the immunization schedule. The next 2 slides, I will put it up in this one, you can read it. I think that's the HPV vaccine is given 2 doses, 0 to 6 months, 9 to 14 years. And above 14 years is 3 doses. Therefore, we will stop the discussion today. You are there with me? Okay. Hello?
Yes, sir.
Okay.
Yes, sir.
I would expect more people to attend. I am really disappointed. Now I've stopped the recording. Let me close the end show. Where is the recording going? Rose, you are still there?
Yes, sir.
Okay. I don't know whether I can stop the recording. Therefore, I would expect more people to appear,